Hello and welcome everyone. Today we'll be discussing about the diagnosis and management of seizure and myoclonus after cardiac arrest. Hypoxic brain injury after post-cardiac arrest is a very common thing. We see persistent coma in ICU patients who have developed cardiac arrest prior. Myoclonus occurs in 20 to 30% of such patients. Epileptic seizures are less frequent but indicate severe brain injury with poor prognosis, though recovery is still possible. Now, myoclonus, its types and features. It is defined as sudden, brief, irregular, involuntary muscle jerks. It can be focal, affecting one muscle group, multifocal, involving multiple muscle groups, generalized, affecting the entire body. Common sites are face, trunk, axial extremities. Stimulus responsive. It is triggered by touch or sound, suggesting post-anoxic myoclonus, not really epilepsy. Now, post-anoxic myoclonus likely originates from the cerebral cortex, sometimes linked to the subcortical damage or the disconnection between the brain structures. Variability exists in how clinicians assess and classify it. Post-anoxic status myoclonus is a continuous generalized myoclonus lasting for more than 30 minutes. It starts within 48 hours post cardiac arrest and then it predicts poor outcomes. Now, differentiating between post-anoxic myoclonus and epileptic seizures. In post-anoxic myoclonus, there are irregular jerks, not typically spreading or lateralizing, steady for hours without any rhythmic pattern. EEG is variable, often shows burst suppression. Whereas in epileptic seizures, you will find highly rhythmic jerks, often starts locally and tends to spread. Lateralization is possible to some site. Recurrent sudden jerks with decreasing frequency, and in EG will definitely find the epileptiform discharges. Now there is something called Lance-Adams syndrome. It is a rare type of post-anoxic myoclonus. The features is action-induced myoclonus in awake patients. The prognosis though is good and no treatment limitations is necessary. Clinical application, EEG to differentiate between post-anoxic myoclonus and status epilepticus is important. Recognize the stimulus responsibility to the identifying post-anoxic myoclonus. Consider timing and characteristics of the jerks for the diagnosis. Rhythmic lateralizing jerks suggest seizures. Irregular continuous jerks indicates post-anoxic myoclonus. Understand that the early identification aids in prognosticating and having a proper treatment plan. Now, EEG, how to use it at the bedside for these patients. So what does the EEG measure? It detects the electrical potential difference between the scalp electrodes reflecting the cortical synaptic activity. This activity arises from the postsynaptic currents in the parallel cortical neurons and is highly sensitive to hypoxia and ischemia. The importance of EEG in hypoxic encephalopathy is that the EEG activity is disrupted within seconds after cardiac arrest due to the cortical sensitivity to the oxygen deprivation. Detecting hypoxic encephalopathy makes the EEG crucial in evaluating the brain function post the cardiac arrest. The clinical uses of EEG. Relatively simple bedside monitoring is possible in most hospitals. Using this, interpretation requires specific expertise and inter-observer variability exists. So the main problem that we face is in interpretation, though monitors are available easily right now. American Clinical Neurophysiology Society has developed a standardized nomenclature for consistent interpretation of the EEGs. Now, prognostic value. Patterns after cardiac arrest help predict the outcome. Reappearance of continuous normal amplitude EEG activity within 12 to 24 hours. In poor outcomes, there is persistent suppression beyond the 12 to 24 hours, suppressed EEG with bilateral synchronous discharge or highly amplitude bursts. High specificity for early prognostication in comatose cardiac arrest patients. EEG in detecting epileptiform patterns. It is characterized as rhythmic and periodic patterns, that is RPPs, by the American Society. Now, up to one-third of the comatose patients show patterns resembling seizures or status epilepticus. The common patterns, though, are generalized periodic discharges, rhythmic delta activity, unequivocal seizures, and electrographic status epilepticus are rare. Without EEG, silent epileptiform activity may go undetected in as much as 33% of the cases. Now, what is the predictive value of these RPPs? Isolated discharge lack predictive significance. However, ongoing RPP for more than 30 minutes is associated with case fatality rate of almost 100%. How to optimize the EEG recordings? Use muscle relaxant to minimize the myoclonus. Avoid high dose sedatives as they will suppress the epileptiform activity. The clinical application is early EEG aids in prognostication of the neurological outcomes, detecting the hidden seizures and status. Recognize EEG patterns associated with good and poor prognosis. Now that we have the idea regarding the EEG and its interpretation, let's see what is the management. There is an uncertainty about using anti-seizure medication in these patients. Debate exists whether the RPPs represent true seizures or indicate a irreversible brain damage. Surveys show variability in practice. One third use stepwise anti-seizure medication for all epileptiform activities. One third use the medications in a non-standardized way, and one third avoid ASMs, assuming that the treatment is going to be futile. Uh, the recent largest trial that has been published is the Telstar trial. The objective is to evaluate whether treating status epilepticus improves outcome in comatose cardiac arrest patients with epileptiform EEG patterns. The intervention group, they had a stepwise ASM use and sedatives to suppress the epileptiform activity for at least 48 hours. In control group, standard care without any ASMs. In the results, there was complete suppression of the activity achieved in 56% in the intervention and quite obviously 2% in the control. No significant difference in poor outcomes at 3 months. Now, in the subgroup, we did get some insight, that is, the generalized periodic discharges, the intervention group had a worse outcome. The electrographic seizures or status epilepticus, the intervention improved outcomes. So, this study, though gives us a lot of insight, is not without its critical issues, which are the fact that there is a high mortality and prognostication in the included patients, with as much as 81% death. Sedative medications were used in both groups, potentially diluting the effect of the ASMs. Short ASM duration, that is only around 9 days, whereas longer treatment may help. Generalized periodic discharges, which rarely benefit from ASMs, dominated the study population, as is seen with the death, that is 80%. Now, subgroup analysis was underpowered, so we cannot make a lot of predictions based on that because the confidence intervals are very, very high. Now, coming to the implications for our practice, generalized periodic discharges, minimal benefits of ASMs, outcome unlikely to improve with ASMs. Electrographic status epilepticus or similar pattern, there you can give ASMs, but probably a prolonged duration may help you improving the outcome. Observational studies suggest a good outcome up to 44% without generalized periodic discharges. Treatment decisions should be individualized, prioritizing EG patterns and the clinical context. Now, in the future directions, a new trial is being designed by the Telstar group to evaluate the ASM efficacy in the electrographic status epilepticus with favorable EEG pattern. Now, the takeaway for our clinical practice is that avoid blanket use of ASMs for any kind of a periodic discharge. Now, consider prolonged ASM therapy for patients with having EEG pattern or with status. Use EEG finding to guide treatment and prognosticate the direction. Regarding what management is to be done regarding the ASM for the post-anoxic myoclonus, which is not in seizures, which will typically resolve within hours without any specific treatment. ASMs are not required. Regarding status myoclonus or status epilepticus, in that case, we can go for prompt treatment to suppress all epileptiform discharges. The role of ongoing seizure activity in secondary brain damage remains uncertain though. Regarding the preferred ASMs, levetiracetam or valproate are the first line. Easier dosing, fewer interaction compared to the fosphenytoin, which is less favorable in the ICU settings. Treatment should follow the standardized protocols given by the Amsterdam University of Medical Centers. And the treatment evaluation should be done on daily basis where you assess that efficacy, and team discussion and family consultations are crucial to evaluate the likelihood of favorable outcomes. Prognostic implications regarding the status myoclonus: it indicates severe brain injury with poor prognosis, reliable predictor if it is generalized for more than 30 minutes and within 48 hours. False positivity rate is 0. So if you find this, there is very high chance that it is severe brain damage, and sensitivity is around 50%. Post-anoxic, the limited prognostic value with false positive rates of 0 to 22% and sensitivity around 50%. Avoid a nihilistic approach. Some patients may still have good outcomes. So just because you find myoclonus, do not just think the patient has died. Uh, Regarding the prognostic implications and the EEG markers, early restoration of normal amplitude background activity is with good outcomes. Late onset epileptiform activity emerging from continuous background activity, patients showing favorable markers often have low neuron specific knowledge, indicating that there is less brain damage. Common predictors for outcome are the SSEP CT-MRI findings, which give more insights, but RPPs can also be used. Recovery is associated with the lower discharge frequency, reduced discharge power, and less periodicity on the EEG. So to conclude, myoclonus, status epilepticus indicate there is a severe brain injury after the cardiac arrest. Generalized periodic discharges do not really benefit from the anti-seizure medications. When you do find electrographic changes in the EEG, ASM can benefit, but the evidence here is weak. Reassess the prognosis regularly, communicate clearly with the families regarding the clinical takeaway, use EEG for your diagnosis and prognostication, reserve ASMs only for electrographic seizures. Focus on multidisciplinary discussion and patient specific decision making. So, this is an algorithm that you can use at your bedside. Start with the EEG. If you don't find any discharge, no treatment to be given. If you find something favorable prognostication and all, start with anti seizures, and if there is no favorable, then there is no need to start treatment. Start additional prognostic test as soon as you get your positive seizure and you start treating it. Reassess it every 24 hours. So you start with levetiracetam, you can continue with propofol and magnesium, then check your electrographic improvement. If it is not available, if it is not happening, then you can add valproate and midazolam. If it is still not happening, you can add lacosamide and the parapenal suspension to the nasogastric tube. If you still don't find it, then there are these new medications which you can use. So this is something which you can use in a stepwise manner, every 24 hourly assessing the patient's condition. Thank you for your patience.